session. Thank you, Esther. Good afternoon, and thank you very much for being here. My name is Ken Goodman. I direct the University of Miami Miller School of Medicine's Institute for Bioethics and Health Policy, but here today in the context of the Florida Bioethics Network, which, as you've noticed from our logo, is along with a number of other things marking its 30th year. This is as we try and pivot to a post-Zoom world and have more nimble professional development opportunities for clinicians and others and interested in clinical practice and ethics around the state. And so this is the first of what we hope will be a number of nimble, shorter sessions with some of the state's leading thinkers, clinicians, and people who do ethics, which is why today I'm really excited to have Dr. Pasquale Patrizio. He is, as you can see or remember, Professor of Obstetrics, Gynecology, Reproductive Sciences, University of Miami, and Chief of the Division of Reproductive Endocrinology and Infertility. He is a leading international scholar in assisted reproduction. And I wanted to, sometimes we have this alphabet soup after our names. And if I may, Dr. Patrizio mentioned the MD y'all know about. MBE is a Master of Bioethics. FACOG means he's a fellow of the American College of Obstetrics and Gynecology. But there's a prize. Esther, we should have thought of a prize. What does HCLD stand for? And no looking it up. You have to know it.
I will let you know soon. Sure.
I'm going to say it and why it matters here. All right. Next time we're going to have a prize for whoever identifies the most important acronym. What that acronym stands for is High Complexity Clinical Laboratory Director. During Dr. Patrizio's presentation, you'll see why some of the aspects, the role of the laboratory in assisted reproduction is so very important. In any case, Dr. Patrizio, thank you so very much for being here. Welcome to the Florida Bioethics Network. I'm going to hand the floor over to you. Our plan is for you to share some thoughts about assisted reproductive techniques in the 21st century, and we're going to have plenty of time for questions and exchanges thereafter. You'll be able to put your questions in the Q&A or into the chat, and we will monitor those after he's finished and be able to have as much of a robust discussion as possible. On that note, once again, Dr. Patrizio, thank you for being here. The floor is yours.
Thank you very much, Dr. Goodman, for the very kind invitation. It is really a pleasure and honor to provide this talk today. And before I go with my talk, I just want to have the slides on disclosure. I'm a co-founder of a small biotech company in Israel, but none of the discussion of today has anything to do with the company. Now, in vitro fertilization has been really a remarkable success. I just want to say this at the outset, because if during the talk, I may give the impression that I'm extremely critical of in vitro fertilization, it is only for defending patient care, quality of care, and patient interest. But in itself, this technology has brought joy to so many couples, and so many babies have been born. At the last count in 2018, there were at least 8 million babies that were born thanks to Professor Bob Edwards, that in 1978 was one of the pioneers in bringing to light Louise Brown in Oldham, UK. Unfortunately, he got the Nobel Prize for this discovery in 2010. Unfortunately, he could not even enjoy that because he was already suffering from Alzheimer, and it was really a pity that he did not understand and get the opportunity to be properly rewarded. A second giant in the field is Howard Jones, that when he was 70 years old, in 1980, he went from Johns Hopkins back to Norfolk in Virginia, and he opened the first IVF clinic in the United States at age 70. And then he was really a pioneer, and he has, there is still an ongoing Howard Jones Foundation, and I'm a member of that board. And in 2019, in pre-COVID time, we had a wonderful reunion in New York, where we were celebrating some of the many hundreds of babies born in the United States from in vitro fertilization. And here you can see them participating in a meeting on where the field should go, because they've been involved in a new development, and they've been keeping abreast of the things that are happening. So this is really a wonderful opportunity to have children, now adult, being part of a future enterprise. Now, what am I going to cover in the next 40 minutes are the following topics. First of all, I want to present some of the so-called add-on or options that fertility practice these days are adding on the a la carte menu of treatment. And some of these options, if not all, are still considered not validated. And therefore, we as a bioethicist, with the bioethical hat on us, we should really be very critical on how we are using these non-proven technologies. The second thing I want to address is women are delaying motherhood. And this is a great opportunity for them to have an opportunity to go to the fertility clinic, to freeze their eggs, but again, is a possibility of exploitation of a very good, remarkable technology, egg freezing. So we need to be careful here too, and I want to go over a few potential issues. I want to explain, that there are some misperception. The 40 is not the new 30s when we talk about the biological clock, and we will see that. Why are women doing elective egg freezing, and who is giving them information about egg freezing in general? And then there is another new technology that has been now proposed, at least in the United Kingdom and in Europe. They're ahead of us in terms of proposing it, which is a way to creating what we call ovarian rejuvenation or postponing menopause. And finally, the new IVF business models, pros and cons on all these venture capitalists, private equity banking that are coming into buying more and more fertility clinics, creating the so-called McDonald's or Starbucks of infertility treatment. So first of all, let's see how are we doing. A recent paper showed a worrisome trend in that there has been a worldwide decline in IVF birth rate. So if you look at this graph, until the year 2000, there was an increase in success rate, let's call it like that. But then from the year 2000 until the year 2013, you see that there's been a plateau. And now from 2014 to the latest numbers, the number of treatment cycles associated with the live birth is on decline. And why is that happening? Instead of being better, looks like we are getting not so good anymore. And some of the explanation is because too many adds-on. These additional technologies perhaps are not so helpful in producing the desired outcome. Let's see some of them. The literature in 2017 proposed that this adjunct in the IVF laboratory, and here are some examples like embryo glue, sperm DNA fragmentation, time-lapse imaging, preimplantation genetic testing, which we will elaborate in details. They really have no evidence, or very, very limited evidence, but they've been added on the service with the hope of improving the success, but at the end is not. The Human Fertilization and Embryology Authority in the United Kingdom has made mandatory that every IVF clinic provide a fully informed consent to patients that are undergoing in vitro fertilization, where they need to be informed that this technology that they've been proposed, this so-called adds-on, they are adding money. Here is between £1,000, £400, depending on the technology proposed, but they have not yet been validated. So the patient needs to be informed that yes, we are using a technology, but is not yet validated. And unfortunately, this is not the same in the United States. To the point that in the United Kingdom, the editorial in Reproductive Biomedicine Online, using the traffic light rating, it shows that in red, no evidence for any of this technology, or amber, there is conflicting body of evidence. But you see in the green, when any of the technology adds on, should be the one that has been proven? None. So you see here, they are either red or they are amber. So there is really not enough evidence, but still this technology are sold with a good number of dollar signs to patients that are not aware that there is lack of evidence. Therefore, in the United Kingdom, many articles have been coming out with IVF rip-off exposed. In the United States, this article that was published in 2019, she put her face, Sarah. She had spent thousands and thousands of dollars to try to get pregnant since age 41. And at age 47, somebody proposed, oh, if you use this medication called the Neupogen, which is a medication that is used for modulating the immune response, generally for cancer patients, for the cost of $3,000, maybe you will be successful. And sorry to say, but unfortunately, she was not. And she went to the newspaper to explain, you know, how much money, more than $100,000 later, she was still without her desired outcome. So what are some of the technology that I want to go into details and go over with you? Let's start with the PGTA, which PGTA stands for pre-implantation genetic testing, and the A stands for aneuploidy, which is a disorder of a chromosome number, chromosome that may be missing, or chromosome that are in excess, okay? Now, the assumption, and therefore the rationality to sell this technology was, well, when we do the biopsy of the embryo, and we biopsy an embryo when it's called the blastocyst, which is a 5 to 6 days embryo that has grown in the laboratory, the rate of mosaicism, and I will explain in the next slides what is mosaicism, is very low. Therefore, the biopsy, the cells that I'm harvesting from the embryos, they are very, very low margin of error. Technique is precise, 100%. It's very accurate, not false positive, not false negative. And also that the biopsy really does not reduce the viability of the embryo. So all of these were all the assumptions. And except the one that is in black, all this in red really have not been proven. Now, what are the facts? This is a blastocyst, you see here. So the blastocyst is a stage of embryo development where the embryo has a hollow center here. And on the outside, there are these cells that are going to form the future placenta. As the baby, the fetus, is right here in this clump of cells in the inside part of the blastocyst. So that's the embryo in itself. So when we do the biopsy, we harvest 5, 6, 7 cells from the outer layer of the blastocyst. In other words, we are taking away from the embryo 5, 6 cells that they are going to be placenta cells. We don't biopsy the embryo, we don't biopsy the fetus, we biopsy the future placenta cells. Now, when we talk about mosaicism, we talk about a mixture of cells. So some are green, which means they will be normal, and some are red, okay? So, when they told us at the beginning that only 1 or 2% of blastocysts, they have mosaicism, meaning they have these mixtures, that was not correct, because today we know that at least 80% of blastocysts, they do have some cells in the outer layer, in the placenta cells, that they are indeed different from the neighboring cells. So therefore they are mosaic. So mosaicism is much more common than what was originally anticipated. Now, if you have all green cells, this embryo is called normal. If you have all red cells, this embryo is called aneuploid or abnormal. If you have a mixture, you are calling it mosaic, okay? But even an aneuploid embryo, because you biopsy 5 or 6 cells, is really not representative of the rest of the cells. There are about 150 cells that they are going to form the placenta, and we only take 5 to make an analysis and assumption of the placenta. And furthermore, another thing that is important, the placenta cells, they are dynamic entities. They keep changing. So they are, if I do a biopsy today at 8 o'clock in the morning, and the result is not going to be the same if I biopsy in another location of the blastocyst at 8 o'clock at night. Now, how do I know, or how do we know that the biopsies results are associated with the poor interpretation and poor accuracy? Because there are many, many babies now that have been born healthy after we transfer the embryos that they were not supposed to be transferred, okay? And you see in the New England Journal of Medicine in 2015, the very first alert paper, it says, look, these are embryos that they were called abnormal because they had this type of a chromosomal analysis. But then we transferred them. Now, you may say, why did you transfer an abnormal embryos? Well, because, you know, these are patients that they spend $20,000, $25,000 to make these embryos, and now they have nothing to transfer, and they don't have another $20,000, $25,000. So they were asking the doctor, can you please transfer an embryo that has been reported as abnormal? I will sign it against the medical advice and so forth. And here, the discovery that, you know, probably the test is not so accurate, because you see that six babies were born, all healthy at birth, while their original testing on the placenta cells was saying that they were abnormal. And the other papers have also been produced showing that there is about 30–40% of babies born healthy after the transfer of the so-called mosaic embryos. Okay, so there is a rate of false positive that is not 1% or what has been claimed 99% accuracy. It's much less, the accuracy. Then I did a survey and I asked colleagues around the world, you know, have you ever transferred abnormal embryos? And if yes, can you give me your outcome? And you see that there were a total of 215 embryos in this survey response that they transferred abnormal embryos. And of these 215, 56 had already delivered, totally healthy at birth from a chromosomal standpoint. 50 were ongoing, and 20 had miscarriage. So it's a low miscarriage rate if you think about only 10%. A paper that came out 7 months ago, and here I symbolize putting a nail in the coffin, is that this was finally a randomized control trials of whether or not there was a difference in the live birth rate between women that had at least 3 blastocysts, where some women, they were in the arm of being biopsied, and some, they were in the arm not biopsied. And there was really no difference whatsoever. In the actually, the absolute difference was more in favor of women that were not having the biopsy. Okay. Now, this paper has been really a fantastic contribution to the literature because it shows that the embryo, the human embryo, has the capability of fixing within some, to some extent, the abnormal cells. And you see here an embryo that is expelling abnormal cells, and these abnormal cells that are the aneuploid cells, they all go and populate the placenta. So in other words, the embryo, to some extent, the embryo itself, okay, has the capability of getting rid of abnormal cells, and the cells are going to be located into the placenta. So if we do a biopsy of a placenta, there is a chance that we may be analyzing those cells that have been discarded and get rid from the embryo. Therefore, the diagnosis is not accurate. And this has been published by us very, very recently in the Nature Medicine, just making the point that there is really a lot of genetic plasticity going on in the early stage of development. It's really important to know exactly where these cells are coming from. And this is really reopening the opportunity for reanalyzing some of the testing that we have been doing, and hopefully the PGTA in particular is going to be seen under a different light. New York magazine said PGT does not appear ready for prime time. This couple from Connecticut had babies born after they were told do not to use these 2 embryos, and this was on the Wall Street Journal. So it's not something that it's just in our fantasy, but those are facts. And from an ethical standpoint, really the scoring of mosaic embryos with the PGT, it's a roller coaster, because it is really not fair in some respect to put the onus on whether or not to accept an embryo that is aneuploid or is abnormal on the patient. In other words, so we are trying to utilize the concept of a procreative liberty, but we are giving the responsibility to patients to decide whether or not they want to have a transfer of an embryo that may or may not be abnormal, because the testing in itself is putting a patient in that particular condition. So therefore, when I wrote this paper a couple of years ago, I said this technology has to be we need to press the button pause, and we really need to get better at the technology in itself if we want to improve it. And that's is my position on that. Going to a second adds-on, this is a very fancy name, time-lapse observation or embryoscope. You see here, there are 3 examples of this embryoscope. What it is an incubator, okay, where you put the embryos in culture. And then there is a photograph that machine that is going to take photograms, and you can adjust at how often you want to take pictures. And this really doesn't, what does it do? It takes every minute or 30 seconds, pictures, 24/7. And then a computer system will analyze how the embryo has been dividing, has been doing the first division within certain time frame, and the second and the third, and so forth. And this has been, so this machine, they've been going for about $80,000, $100,000 each. And of course, you buy also some of the pods to make sure that they fit the system that you have. And of course, the cost has been passed on to patients, but do they really work? And really the answer, finally, when they do the studies in a randomized control fashion, that the addition of this time-lapse cameras does not significantly improve the reproductive outcome. And in fact, the Cochrane review that was published in 2018 also say that, you know, the time lapse, it's not really improving over the conventional incubation. So it's not really the fact that you take the pictures, but it's the fact that when you take pictures and you leave the embryo in the incubator for 3 days without opening and closing, and if you compare the same, keep an incubator without the camera for 3 days without opening and closing, at the end there is no difference whatsoever. So there is no reason to buy this machine, spend all this money, and pass on this to patients when there is really no benefit. Another unvalidated adds-on is the so-called freeze-all versus fresh transfer, okay? And again, I just selected the 3 of them. I'm not going to go through all of the 26, 27 adds-on, just because I want to go with the most important ones that are still proposed, widespread proposed in our communities. Now, the question here was, you know what, we should create the embryos. We do in vitro fertilization, we create the embryos, but don't do the transfer when the embryos are fresh. No. Let's freeze everything. Let's freeze everything. Let's completely dissociate the cycle where we make the embryos to the cycle when we are going to do the transfer. So if a woman produces 3, 4 embryos, we will freeze all of them. And then we will tell her now in a month, 2 months, come back. We will defrost the embryos, so we will do the transfer because the success rate is better. Well, these are now 2 cycles, right? So 1 cycle to make the embryos, and another cycle, the second one, at less cost, yes, but it's still another cycle. Then we do the transfer. But is there really a reason to do the freeze all or freeze only in every single patient that comes through the door? And here, another randomized control trial, New England Journal of Medicine, very important journal. You see that there was really no difference, no significant difference in whether you do the fresh or you do the frozen in general. Of course, in particular, there are some cases that you want to do the freeze-all, and these are only 3 cases where you want to do the freeze-all. First, if the patient is hyperstimulated, she has more than 15 eggs, the endometrium, the uterus, may not be so receptive when you have too much estrogen around, okay? That one has been proven that it is a good idea to do that. But if a woman has up to 14 eggs and the level of estradiol is not that high, you should do the fresh transfer. There's no point to do the frozen transfer. The second is when a woman has a premature rise of progesterone, okay, that may impact implantation. That's a good idea. Let's freeze everything. And the third is if there is a reason to freeze the embryos because the patient is undergoing preimplantation genetic testing, not for aneuploid, but for genetic conditions, for structural anomalies. So that is very accurate, that diagnosis, by the way. It's the aneuploid that is not so accurate. So if there is a reason to do biopsy, you want to avoid cystic fibrosis, you want to avoid the spinal muscular atrophy, or whatever genetic reason, that's another reason to freeze everything. So in summary, for the freeze-all, I prefer fresh tomatoes over frozen food. I'm sure you do the same. So therefore, we should not really add cost, delay pregnancy if it's really not properly indicated. Now let's switch gear and go to another important, interesting phenomenon that is going on in our society. And that is that the age of first of a mother has been going up. It's about 28 and a half, not only in the United States, but also in Canada, that the age of a first mother is now 30-year-old. So in the last 2 decades went from 27 to 30. And you can also, see that even media celebrities, they are having children in their late 30s. So the U.S. fertility rate is down, yet more women are mothers. But these women that are mothers, look at this interesting graph here. These are all women, but then in reality, if you look at which age group is now creating a little bump upwards, are women that are over the age of 40. So in other words, there are more women after the age of 40 that are coming to the IVF clinic, they are seeking help, or they are getting pregnant. So this is an interesting phenomenon. And in fact, if you look at the CDC national data on assisted reproduction, a significant portion of our patients are now 35% of them, they are 38 years or older, and in 2017, this became 40%. So there is a significant number of women, they are coming to IVF or reproductive clinics, and they are over the age of 38. And this has really dramatically increased, this number, this percent, over the last 15 years. So not only in the United States, even in Europe, you see that the number of women 35 to 39 or 40, you see here that how the 40-year-old group has been going up also in Europe. So what's going on? And how should we deal with this type of situation? Should we treat women that are 45 years old, 43 years old, 46 years old? So the American Society of Reproductive Medicine put on an ethical committee opinion. And here they came up with the 2 classifications. One is we probably should distinguish patients that have a very poor prognosis of treatment. And those are the ones that they have a chance of less than 5%, okay, 1 to 5%. And then we should also label those that have less than 1% as a futile treatment, futility, okay? So now, here we can start the discussion maybe later, is this really something that is the best way to talk to patients and say, oh, you are 45, your chance is less than 1%, so therefore the treatment is futile, I'm not going to do it. What if the patient says, no, I understand it's less than 1%, but I still want to try to do it? Because if I don't do it, I'm going to have regret for the rest of my life, and I still want to do it because maybe that's the way for me to accept another option, which can be adoption or can be donor eggs. But if I don't do that, doctor, I'm not going to be myself. Are we still going to say, no, I'm sorry, the SRM says that this is futile, I should refuse, and I'm not going to do it? Well, again, I think every single center should develop policies, and they should know if there is this type of dilemma or challenge, that we should have some guidelines, okay? And these are really the importance of creating these guidelines, in particular on how to navigate through the process, decision-making, which age should be the cutoff. And by the way, if we use women age cutoff because of futility, what about men? I mean, we should never forget that even the father age may play a role in infertility, and there are significant data now accumulating that advanced paternal age, defined as a man of 55 or older, can be associated with the higher risk of schizophrenia, autistic children, and some other conditions. So anyway, this is just to say, age is an issue. How old is too old has to be addressed, and clinics should come up with their own guidelines. Okay. Now, but who is educating women, and where do they get information? When I was at Yale a few years ago with one of my bioethical students, Paula, a Brazilian student, we did this study on of inquiring with women that were coming to the IVF clinic, 43, 44, 45, and when we were telling them at age 43 or 44, you know, the chance of having a successful live birth, it's probably about 2 or 3%. They were looking at us in shock, in dismay. So what are you talking about? Did you see my strength here? I go to the gym every day. I don't smoke. I eat organic foods, and you are telling me that I'm only have 2%. Something must be wrong with your clinic. And then at the end, you know, we realized that there is really a persistent misperception on women, that they think that they go to an IVF clinic and the IVF clinic can fix the aged biological clock. And you know, of course, we are not helped by media, celebrities, that they go on front cover showing that they are pregnant, but you know, they don't know at age 50 or 40, you know, like, are they using their own eggs? Most likely not, but that is not said. So is there any way for women that are not had the chance yet to find Mr. Right, or because of their career, to protect or preserve their future fertility? And the answer is yes. There is a remarkable technology. It's called egg freezing. And when women, they want to protect their future fertility, they do what we call elective egg freezing. Before it was called the social egg freezing, but there is really nothing social in doing an egg freezing. It's still a surgical procedure, so it's better to call it elective egg freezing. Now, where are they getting the information? And here is now the ethical quandaries. You see that, and this is all pre-COVID time, there were companies that in New York, in San Francisco, so in all major metropolis cities, they were organizing party. They were calling it the chilling out at an egg freezing party. I am so excited, offering some candies and so forth. And they were inviting some clinician to talk to a group of professional women about the benefit of egg freezing. And while they were having also sipping some martini cocktails, someone was going around, and I know this because a reporter went in incognito and told me this. They were going around with informed consent after a glass of martini or two, signing up with me. I give you $1,000 discount if you do it. I wonder who, you know, in the sane of mind would sign a consent with a couple of glasses of martini in a party under peer pressure and so forth. But anyway, so that's where they were giving information. And another information that they were getting is from this company that is called the Kind Body. And this Kind Body now has bought another private clinic called the Vios. But anyway, what they were doing, they were parking this yellow van outside the Source Cycle, outside the Dry Bar in New York, and then all these people dressed in yellow shirts, they were inviting the girls coming out of the gym and from Dry Bar, go in the van, take a blood samples, I check your hormonal ovarian reserve, and then, you know, if you sign up, we give you $500 discount, and then you are going to do a cycle of egg freezing. So you know, there is really nothing kind to your body if you ever to do egg freezing. But beside that, you know, these were really trying to capture 25, 26, 27, 28 years old women that, and they were trying to do egg freezing just on one simple test. And there are a lot of ethical problems that I have with this type of activity. And therefore, you know, this is something that I criticized a lot. I wrote about it, and then the COVID came and the yellow van disappeared, but the clinics are still open. Now, what was missing in the debates, you know, what the women themselves say. I mean, and therefore, you know, why are they waiting to have children? Why do they turn to elective egg freezing? The dogma that was present in literature at the time was that, well, women are freezing eggs now, or they are not having babies because they are in career. Well, that's what was the dogma. We did a study July 2014 to August 2016 with Marsha Einhorn, an anthropologist at Yale, together with Daphne Birnbaum from Israel. And what we did, we looked at women that had the frozen eggs in the United States and in Israel, and we start to ask questions. And first of all, we start to see what was the demography of these women. They were with the degrees, BA, MA, some doctors, some lawyers, 32% Ivy Leaguers, 26% other elite universities, so really highly educated. The overwhelming majority, we had 114 in the United States, and we had 36 in Israel, but the overwhelming majority in both countries were single women, okay? That they came and froze the eggs. So the main finding was that this, you know, career women, they were without the man. So, and they were telling in the interview, this was 1 hour interview with the anthropologist, that the reason why they were doing elective egg freezing is not because they were in career or to postpone their fertility, but other than because they did not have a partner to whom share the possibility of having a pregnancy. So they were single and they could not find a partner. So then the main question of why there are so many high achieving professional women that cannot find husbands. And with the help of John Berger, a sociologist, we started to, and questioning these women that froze eggs, you know, really women marry up while men marry down. So women at the top have fewer men to marry because as I will show you, there are more women than men that are getting, they are going to college and they are getting graduated. So women are smart, also that are smart and confident, they have very good jobs. They also can be intimidating to men. And the online dating is creating a limitless marketplace of options, especially for men. So when we looked at the college story, you know, there are 4 university grad women for every 3 university grad men in the United States. And therefore, there are more and more women that are getting a degree. So there is a gender gap in college, but 47% in favor of women. And this is not only in the United States. It's happening also in other countries. We looked at another 75 countries and we find the same issues. So more women than men are getting an education. And like John Berger wrote in his book, Datonomics, that dating is now becoming a loop-sided number game. It is really important that we realize that there is really a kind of a demographic time bomb for marriage-minded heterosexual women, because there is a deficit of men for women every 3 men, and an oversupply of smart and articulated women. So this is what the main reason, really. It's lack of a partner why they are coming to freeze eggs. Now, is freezing eggs economically a good decision? Do women that they do and come and do egg freezing, do they have all the information to make the decision? And I personally spend 1 hour talking to women when they come for consultation to egg freezing, because I really feel the obligation to provide as much as information I can in a way that they can make really an informed decision. It's not a 10 minutes, sign here, sign there, and if you sign now, I give you a discount. No. Now, let's look at this paper from Zion Ben Raphael that really stressed a very important point, in that if you freeze eggs, how many people are coming back to utilize those frozen eggs? And you see that the utilization rate is extremely low. The utilization rate was between 3% Australian study from Carey and Hammerberg to 9% from a study from Spain. And you see that when you freeze so much, and this is all cash paying business, and only few people are coming back, now you are cashing in on women that they are frozen, you are cashing in on the cost of the storage, and very, very few are coming back and utilizing the eggs that they've frozen. And also, how many eggs do I need to freeze? And in order to have a chance of a pregnancy, because that's another important point, I mean, I really stress with my patient that, we are not really freezing. You do not have any insurance that at the end of the day, there is a guarantee for pregnancy. You are freezing a chance, is a likelihood. But you see how many eggs you need at age 34 to have a 90% chance of a pregnancy. You need to freeze 20 eggs. If you want to have a 75% of pregnancy at age 34, I need to have at least 10 eggs, at 37, 20, and so forth. So more cycles, more potential for more money that has to be invested in that. So that's the paper where I addressed the ethics with my mentor, Arthur Kaplan, where it is important really to discuss the number of cycles, the cost, success rate, cost associated with keeping the eggs in storage, cost associated when you are going to use those eggs when you come back, and the chance that at the end of all of this, you may still not be successful because there is no 100%. Another technique or procedure that has now been put on the market in UK is the concept of can we extend the endocrine lifespan of women that are now going into menopause. So if we are able to freeze ovarian tissue, and we learn how to do this really well for a patient with the cancer, we are taking a piece of ovarian tissue, we are freezing that ovarian tissue after the patient has chemotherapy, radiotherapy, and she become completely infertile, I can retransplant back into on her ovary that is now non-functioning. I can retransplant back that ovary cortical tissue that I had taken away before she undergo chemotherapy, and now she can resume her ovarian function. So then the concept, well, if I can do that for cancer patient, why not to take a piece of ovary in a woman that is 30 years old, let's freeze it for 20 years, and then when she's 50, that she's starting to suffer from menopausal symptoms, I can retransplant the tissue back to her, not necessarily on her ovaries, because I don't want her to get pregnant, perhaps, but I can put it back on her forearm. I can retransplant it in the abdomen, for example. At least she will have the endocrine function. And we are going to take care of this $1 billion dollar money for osteoporosis, insomnia, irritability, so we don't need to give any more hormonal replacement and so forth. So the concept is enticing. So this is the colleague in Denmark that proposed it. I wrote a rebuttal piece saying yes, but not too fast. Well, I want to make sure that before we do propose this type of technology, we are now going to have two things. One, how sure are we that an ovary that has been frozen for 20 years and then you are going to to use it is going to last another 20 years. So let's do some animal experiment first. And the second rebuttal was, how do we know that if I put back an ovarian tissue in a woman that is 50 years old, I may start to trigger new onset of breast cancer or any other cancer that are hormonally dependent? ? But UK said, no, we have a technique that we can start to sell. So between $7,000 and $11,000 pounds, sorry, which is more than $11,000, has been offered to women up to age of 40 from this Birmingham-based company. And therefore, these women now, they've been told, if you pay this money, I take a piece of your ovary, when you are in menopause, you come back, and I'm going to put back that this ovarian tissue. And this has been now allowed to this company since 2019. And finally, I want to conclude with the investors and investment bank and private equity and venture capitalists, that they are seeing infertility as a big business. And this is really transforming the industry. And I'm much more concerned now than I was a few years ago. Because really, in addition to do a very aggressive marketing and being offering treatments that are poorly validated, if not validated at all, what I'm worried that this changing world of IVF may have some deleterious effect, not only on training and academic centers and the small clinic that are doing their own job in the best possible way, but most importantly for patient care, for patient quality of care. Now, of course, there are some pros in putting these things together, clinics together, chain of clinics, chain of operation, okay? But these are so far all theoretical, because the inflow of capital could accelerate commercial development of new IVF clinics, but so far we haven't seen. And those clinics that are being open, they are not open in rural spaces, so in places where there are missing clinics, but only in area with affluent, where income is higher, and therefore they are not really trying to do it for improving access to care. They could lower the price of a treatment, but they are not. They are adding on so much, therefore yet to be seen. And they could also do lobbying to insurance to cover IVF, right? But would they? And the list of cons is much longer. So the risk is that small practices will be swallowed. Now, of course, has happened already in the airline industry, hotel industries. There is all this merging, of course, in dentistry, orthopedics with the special, with the Center for Special Surgeries, dermatology practice. But with in vitro fertilization is happening purely because there is an opportunity now that they want to capitalize, and they are going in very, very aggressively. So they are offering only expensive treatment. They took the R out of the reproductive endocrinology and infertility. They took away the E from the REI subspecialty. So they only do infertility. They don't do any more endocrinology. Women with polycystic ovary, with the thyroid disorders, with the prolactin disorders, for example, or with they need intrauterine insemination, they are shifted to other places because they only want to do in vitro fertilization. They want to sell egg donation. So an older woman in their clinic is not going to be given a chance, even if it's a little bit better than futile treatment. No, you need to do egg donation because it brings money. So anyway, I'm worried that few academic programs will survive. Who is going to train the new generation of reproductive endocrinologists? And I'm sure that they will be keeping the insurance out of covering in vitro, because that will be only headaches. And also in particular, young physicians, embryologists, nurses, they are lured into getting a job in this chain, but the chain at the end of the day doesn't care about the training, about creating a team of and creating a career for them, because they are just seen as commodity. Therefore, this infertility service is really rapidly evolving in large commercial entities that is, in my opinion, threatening patient care. and the future of research and training for academic centers. And that's all what I have to say today. Thank you so much for your attention. I'll be looking forward now to the question and answer session.
Thank you very much indeed. An extraordinary, I'm not sure what the right word is. Industry doesn't somehow seem right. And yet what you're describing with add-ons and all the other kinds of things is a business model that you're used to out everywhere else, which of course, I suppose if someone is keen to reproduce, you're also keen not to upset your doctor very much, right? And so you've got a population that's a bit cornered here. Let me ask you, but there are a couple questions already, but let me ask the first one or two. In Florida, I mean, you've been here now all of well, less than a year, having arrived from Yale. This is a business that seems to track some of the aspects of medical practice that we try and tell our students they ought not. It's not the kind of practice that you want. If you're helping people, if you're healing, if you're correcting some sort of thing that doesn't work, what's the business with the add-ons? How did we adopt the used car model? And are you familiar with what the lay of the land is in Florida?
Well, not in particular for Florida, because I don't think that is going to be particularly different than other of these chains that are operating in other states. I mean, I want to believe, okay, I wanted to believe that the overwhelming majority of my colleagues, when they are utilizing a particular technology that has been proposed, they probably do it because they, there is some literature that support the use of this technology, of this add-on, but that literature is flawed for many reasons. One is because they are not randomized controlled trials. Second, they are from centers that have a huge conflict of interest. And unfortunately, I don't know in your field in bioethics, but in our own field of reproductive medicine, some of the journals that are leader in our field, when you see that on the editor-in-chief or main editorial board are colleagues that they have private clinics and that they are venture capitalists themselves, and they are the one that they have to decide whether a paper that is saying the opposite on what they are selling. So that's problematic in itself. But I want to believe that the great majority of our colleagues, they try to do this in the best possible way. But one thing is when you have your own small clinic and you decide for your own patients. Another thing is when you have to respond to your investors. And so many people have now to kind of gain from that particular cycle. So one thing is to charge, let's say, just for the sake of our discussion, $10,000 for an IVF cycles. Yeah, but $10,000 now you need to pay the doctor, you need to pay the fancy office, you need to pay all these additional costs that you pay because you want the best of the best. Yeah, but then you also need to pay the investors. So then 10,000 is not enough. You know what? Let's put a free zone. Let's do a second cycle. Let's put the PGT technology. Let's put, and this is a cash-paying business. So that's very risky.
Yeah, there's if you were looking to make money, I would strongly advise you not to invest in bioethics. You'll be able to figure out how to acquire vast wealth that way. Let me ask you, there are a couple of questions here. One of them is there a specific maternal age beyond which you recommend PGT uniformly?
Well, unfortunately, from the way that I see this test, it's a good test for women that they don't need it. So if you have a few embryos, definitely I will not do it. And a few embryos usually is for women that they are over the age of 40. They generally don't produce too many blastocysts, where that's the stage at which you can, you can do the biopsy. Because if there is a risk for error interpretation because of the mosaicism, now I'm going to tell you that I only tested 2 or 3 embryos, they are all abnormal. What do we do? And furthermore, what is also very interesting is that after you do the PGT testing and you transfer an embryo and you are pregnant, you are still required to do a confirmatory test, they still need to go to maternal fetal medicine, and they need to do a test between 9 and 11 weeks, the cell-free DNA. So it's not really enough to do the test and spend this additional $4,000. But that's really, when you say, but it's an add-on, yeah, but it's not $300-400. It's another $4,000. At the end, what do you do with that information? So I don't recommend to women that are of advanced age. Just let nature do the course.
In terms of pre-implantation genetic testing, is it? I mean, this has been an issue for some time. Our colleague Tracy Cohen asks, how reliable is it for determining diseases like cystic fibrosis, for example?
Very reliable, very reliable. On that one, there is no question about, okay? And also when there are balanced translocations, there are some structural chromosomal anomalies, that is very reliable. What is not reliable is just counting the number of chromosomes or small deletions on the chromosomes. That's not reliable. Because what we are learning, and that's, again, I want to stress, what we've been learning in the last 2 or 3 years, that embryos are a dynamic entity. I showed you very, very nice photographs that the embryo really gets rid of abnormal cells within some limit. There are too many abnormal cells, the embryo does not make it. But if there are a few cells, get rid and put it towards the placenta cells. And more importantly, I did not have the time to say, but now that you are asking, probably if it's so true that at least 80% of embryos, if no more, have some clones of mosaic cells. In other words, in the placenta, there are some cells that are abnormal. What's the meaning on that? Why human beings, they start like that? Well, when did we use the name aneuploidy in a scientific terminology? That was in the 1950s. And who started it? A pathologist. Why do they say aneuploidy? Well, because they saw that the cancer cells, they have an abnormal number of chromosomes, and more abnormal cells they have, more abnormal chromosomes they have. So that is a criteria for invasion, okay, for spread. Well, maybe, and this is a big maybe, if there is an area of the embryo, the blastocysts, that are particularly located with aneuploid cells, maybe that is a surviving skill, a surviving trick that the embryo makes in order to implant, invade the uterus and look for blood supply. So that's the way to survive in a way.
Natural selection doesn't
possible, yes.
After a few million years of hominid evolution, we figured out in the laboratory how to try and give it a little bit of a boost.
That's the beauty of our discipline.
Dr. Patrizio, I want to thank you very, very much for being with us this afternoon. I'm noting the clock and trying to make sure that we stick to our program. Welcome to Florida. Welcome to the Florida Bioethics Network. Dr. Patrizio, in addition to his role in assisted reproduction, is a longtime contributor to the ethics literature. It's a real treat to have you in Florida, and we look forward to conscripting you for future FBN activities in the future. On behalf of the FBN, the Florida Bioethics Network, and the University of Miami Institute for Bioethics, Dr. Patrizio, thank you so very, very much for being with us this afternoon.
Thank you.
And to all of you participating, thank you for being here. This has been recorded. We'll be putting it on the web after a while. On that note, thank you all very much, and we will see you at our next event for the Florida Bioethics Network. Thank you and goodbye.